And it's a pleasure for us to be here sharing this session. No, I don't need these slides. I'm just going to introduce. The next talk is Dr. Gombos, so if you want to put it up. So this panel is formed by experts in the field of retinoblastoma, especially treating high-risk features. So we have, for the oncology representatives here, Dr. François Doz from Curie Institut in Paris, France, and he will give us his opinion about how to treat these patients. The other oncologist is Dr. Morali Chintagompala. He comes from Houston, and together with Dr. Dan Gombos and I, we are part of the Retinoblastoma Center in Houston, where multiple institutions are together to treat these children, including Texas Children's, MD Anderson, Baylor College of Medicine, and Houston Methodist Hospital. So our first talk will be given by Dr. Gombos, and he will put in perspective how these patients clinically can be diagnosed with probable high-risk features. Dan.
Thank you, and it's a pleasure to be here today. So when I was assigned this topic by Professor Barrios, she said, Dan, I'd like you to give a talk on probable high-risk features, and I thought, great. This is forward. These are my disclosures. They're not really related to this particular talk, but I do get funding from Children's Oncology Group. So I thought to myself, great, this is a great talk. We can finish it in one slide, because there is no way of knowing who's going to have high-risk histopathology. Not really. And what do I mean by that? I think all of us who've managed retinoblastoma and subsequently had an eye that was enucleated, for whatever reason, continue to be surprised, sometimes shocked by what the ocular pathologist tells us. Sometimes there are eyes with a profound amount of disease. We're expecting it to have very significant high-risk histopathology, and we find that it doesn't. Maybe, in fact, no invasion of the choroid or the optic nerve at all. And then there are other cases where, for all clinical reasons, we think the optic nerve looks good, we have good visualization of the optic nerve, there's nothing really suspicious, and then Dr. Chevez-Barrios calls me and says, we have a problem. So I would say that there isn't an absoluteness, but there are clues. There are clues that can sometimes help us. And so when we present cases at our multidisciplinary tumor board, Dr. Chevez-Barrios is there to say, you guys should worry. Now, one thing we often talk about is neuroimaging. And in our tumor board, we ignore neuroimaging. People think that an MRI is going to give you all the information you're going to need. We have this magical, great tool that provides us an enormous amount of information. But there have been significant studies by people like Jonathan Kim and the group at LA Children's with Jesse Berry, as well as Matt Wilson, who've actually suggested that there is a negative correlation. What do you mean by negative correlation? It means that the scan tells you there's a problem and the pathologist says that there isn't, and vice versa. So you have to be very cautious about what the radiologist says. There are some times, however, where radiology information is very interesting, particularly when you have significant, massive disease along the optic nerve component in the orbit. And certainly those areas need to be perhaps a patient where you say, we may have a problem with high-risk histopathology and extension past the lamina cribrosa. And certainly if there is disease that looks like it's extraocular, that is of concern. But here again, you always have to take a little bit of grain of salt with the radiologist report. In the end, it's the pathologist that always has the final and correct answer. I would say another situation that concerns me, and Dr. Galli alluded to this earlier, is when you have a disease that is very advanced and you simply cannot see the optic nerve. Now, that may or may not be a situation where you ultimately have high-risk histopathology, but I think all of us as clinicians feel much more comfortable when we can see a nice, sharp optic nerve. And in a case like this, which is a case of a child with bilateral group D disease, there is no ocular structure of an optic nerve or macula or anything else to see because the eye is just filled with tumor and a massive retinal detachment. So I would say those cases may not have high-risk histopathology, but they worry me a little bit. Where's a real area where sometimes we can have some better clues? We've talked about there are various grouping and staging systems that are out there, but I think most of us, even though we've talked about the TMNH classification or staging system, clinically we all use the ABC system, and I still like to say the Murphy system because it reminds me of all the clinical work that Lynn and Brenda did years ago to get us this system today. And I think there's general consensus that if you look at this system, the way it was designed, it takes eyes that had early disease from the letter A, and it's really a natural progression of how this tumor progresses and goes from an A to an E. And we certainly know that D and E eyes are more advanced. Well, that's really our first clue as to eyes that may have high-risk histopathology, because there have been studies that suggest that particularly groups that are more advanced, group D and group E in particular, are more likely to harbor histopathology. And particularly when we see neovascular glaucoma, I think all of us on our tumor board get concerned. And I can tell you, when I present these patients at our multidisciplinary tumor board, and Dr. Chevez-Barrios is there, and I say this eye has neovascular glaucoma, there is a strong, we should really consider the possibility here that there's high-risk histopathology, and that has to play into our thought process. And finally, I think Dr. Jonathan Kim, alluded to this earlier. We've all been in situations where there's an enormous amount of work to try to save an eye. Historically, it was the remaining eye in a bilateral case, but we now see cases of unilateral disease where there's an enormous amount of therapies undergone to save an eye. And when these eyes continue to fail therapies and continue to be problematic and we can't get those eyes under control, those are eyes that worry me. Those are eyes where I'm concerned what type of histopathology we're going to get if that eye succumbs to enucleation. So just so we can stay on time, I would say there's no absolute clinical standard to absolutely know whether you're going to have high-risk histopathologic features. And I would say don't get too excited about MRI scans because MRI scans can mislead the clinician and the team. But there are situations where I think you do have to have some concern, particularly more advanced group E eyes or eyes that have been overly treated with multiple modalities that continue to fail. Those are eyes, I think, where the clinician has some clues. And again, if you're working, most centers work in a multidisciplinary fashion, so the pathologist and the pediatric oncologist are sort of aware as the ocular oncologist is sort of discussing these patients, and so there's a planned preparation for what may be to come. Thank you.
Thank you, Dan. So now, can I have my presentation, please? I will discuss what do we, from a pathology point of view, we can say and diagnose which patients have the high-risk histopathology. Which one is that? Yeah, I don't have any conflicts to report. So as the way we had been hearing the whole day is that those children that have the tumor contained to the eye are the ones that have more chances of curing. But any time that the eye comes out of the eye, the tumor comes out outside of the eye, there's a possibility of metastasis. And when we have these huge tumors outside of the eye, there are constant micrometastases happening in these patients. So late diagnosis, as we see here in these countries that I point out here, is the cause of most of the deaths related to retinoblastoma. So here we have an eye that has a contained tumor inside of the eye. There's no outside spread of the tumor. And as Dr. Gombos said, there are some features in the eyes clinically that you can suspect that they may harvest high-risk features, and these are in the D and E eyes. So what happens? This is a normal eye, and the tumor arises from the sensory area of the eye, the retina. Any of these nuclear layers will have the possibility of having the tumor arising from there. The problem in here is that the vascular coat that nourishes the retina is very vascular, so the tumor can go through there to the systemic circulation. And also the optic nerve can be invaded and then is connected to the brain and carry the tumor to the brain. And the other area that people often forget is the sclera, which is the coat that covers the eye, can have these emissary channels, so where the vessels come in and out, the tumor can track these vessels and come out. And these are very small areas, and if the sections are not taken carefully through this area, one can miss these areas of spread. As you can see here, this is coming out. This is the tumor, the choroid, and the tumor coming out in the emissary channels. So how does retinoblastoma spread? There are three main areas where this can happen. The optic nerve, it can go through the tumor inside of the eye. This is the brain and the optic nerve connecting inside of the brain. So it can go through the optic nerve in the proper, or it can also go through the meninges, which carry the fluid inside of the optic nerve to the brain and can spread that way. It also can go through the choroid that we saw, the vascular layer, into the systemic circulation, and then spread into the bone marrow and have systemic metastasis. The same thing happens when it goes to the orbit, because there are vessels there and it can spread further. The last one and the least common is anterior invasion, when there are these larger tumors coming outside anteriorly. In this area, we have lymphatics that we don't have in other areas, and so it can go to the lymph nodes in the face. So these are the modes, and those are the areas that we, as pathologists, have to really focus on. So after all these treatments, many times, the first option, as you heard, could be the enucleation for treatment, or it could be a secondary enucleation after other treatments have failed. So one of the very important part for the pathologist, the person taking care of these eyes after they had been taken out, is to properly handle these eyes so that you can really look and find all of these little clues that can give you information about high-risk features. One of the things after taking out the eye, and if you are going to take fresh tissue, you can do that, but before even touching the eye, is to take a cross-section of the optic nerve margin, because that will tell us if the tumor is at the end cut of the optic nerve, and that would be a high-risk feature. We look at the meninges and we look at the optic nerve itself. And then we carefully fix the tissue and cut it, the eye, in three pieces, with the central portion, with the optic nerve, the tumor, and what we call the calottes. They are little caskets. And then we further cut the calotte so we can see all the choroid for the possibility of invasion. So in 4 blocks, we can study the entire eye. What are the prognostic features? Extraocular extension, of course, is the worst because it's already there. So we see the eye and it has extraocular extension. Then the optic nerve invasion. What it really is a high-risk feature is when it goes posterior to the lamina cribrosa, invading outside of the eye confines, or if it is present in the meninges. And then choroidal invasion, we say more than 3 millimeters is bad prognosis, and there are other, but those are the most important ones. This is a picture of an eye with a tumor. This is the optic nerve, and this is the lamina cribrosa that is more or less at the same level of the sclera. So when the tumor penetrates beyond the lamina cribrosa. It's outside of the eye, and it's in its way to the brain. And this is a high-risk feature that unless we have a good section and the sections had been taken properly, we would not see this. So this is very important for the pathologists to know that they have to get this section to evaluate the high-risk features. And here it shows that this is the lamina cribrosa in a normal eye, but if the further the tumor goes, the more probabilities of metastasis there is. However, even if we do not find tumor in the cut margin, but there's a lot of tumor post-laminar, you can have recurrence in the CNS because they may be non-detectable tumor cells that went through the meninges. Choroidal invasion, we call choroidal invasion massive when it's more than 3 millimeters in diameter and it touches the sclera. In this case, that's massive choroidal invasion. This is focal, less than 3 millimeters, not touching the sclera. In a prospective study that the Children's Oncology group did, the first one prospective, we look at enucleated eyes primary, no treatment, 313 patients. The ones that we decided that had high-risk features were 93 of this we treated. And the ones that have very few focal involvement concomitant with laminar or choroidal were few, but they didn't have any problems. The ones that recur and really have recurrences were the ones that have high-risk features together, like postlaminar cribrosa and massive choroidal invasion. Of these 15, 3 of them recur and 3 of them died. So all of them were not salvageable. Other cases that were not treated but had focal recurrence, they have systemic or focal recurrence, they were salvaged. What is the difference between these patients and these other ones? The difference that I found in all of these went back is this massive retrolaminar invasion together with this choroidal invasion at the edge of the optic nerve involving these areas in here, vessels outside and the optic nerve. All of them more than 1.8 millimeters of invasion and more 4 millimeters of choroidal invasion. So bottom line, the ones that are systemic, not in the CSF, currently can cure of these relapses. The problem are those that have CNS relapses. And so now what is happening and maybe advisable is to do the liquid biopsy, which is looking at the CSF and see if there is any residual tumor in there or RNA detectable. In these cases, especially the ones that have high-risk features like the ones that I mentioned. So probably treating more aggressively, we can do something about these patients. The hypothesis is that when we treat these high-risk features, these tumor cells are already in the brain and they act as a sanctuary site after treatment. There are other histopathologic features like anaplasia, so the cells are very poorly differentiated. This is not really proven prospectively. This is a paper of retrospective study, so we need to really test this in a prospective trial. And lastly, these features are here in the AJCC classification, and just the PT4 are the ones that are having, a stage 2 in the new classification. I'm not going to talk about this because there's a talk later on in this meeting about this. So, adequate handling of enucleated eyes to evaluate high-risk features is very important. More than 3 millimeters or orbital invasion alone may give systemic bone marrow recurrence. Postlaminar invasion with extension into the meninges goes to the central, to the brain. And postlaminar optic nerve and concomitant with massive choroidal invasion may also have a recurrence in the CNS, and these are the ones that carry the worst prognosis. Thank you. So now we are going to hear from Dr. François Doz and see how he approaches these patients that have a report of high-risk feature histopathology.
Yeah, thank you. Thank you for the invitation. So we will share our approaches, which are now more collaborative studies than purely Curie Institute approach. So it starts still with a Curie Institute study more than 25 years ago about retrospective study of histopathological risk factor, and most of the studies are performed this way, and they are the basis for current criteria of adjuvant therapy after enucleation. So we see that these prognostic criteria, just mentioned by my colleague, are really important prognostic factor for survival. This is overall survival, and you see when there is a resection line of optic nerve involvement, the probability of survival is much lower than when there is no or prelaminar involvement. So enucleation is still often necessary, as we have seen in the previous talks in retinoblastoma, at least on one eye in bilateral retinoblastoma, and we hope most often only on one eye. But the surgery has to be performed after imaging. MRI, I agree of course with Dr. Gombos, but MRI, as he mentions, may detect extraocular involvement, like extrascleral or important optic nerve involvement. So it is very important to have this MRI before enucleation. And also the enucleation has to be performed by an experienced surgeon, having a long enough fraction of optic nerve and avoiding rupture of ocular globe. Otherwise, pathological criteria cannot be really studied. So, and the histopathological examination, you understood, that needs to be done by a trained, very experienced pathologist, doing tumor sampling for molecular analysis, and complete examination of the eye, as just mentioned. So it's again it's a global paper where everybody agreed on the modalities of pathological exam. Not only people around this table, but some of the people around this table are authors of this paper. And obviously, we all agree that when there is residual microscopic disease after enucleation, these are very high-risk group of patients. That means when there is an involvement of the resection margin of the optic nerve, and when there is a microscopic extrascleral involvement, these children should be treated by chemotherapy and radiation of the orbit. And I think there is a world consensus about these therapeutic indications. In the situation where the risk is intermediate, we have retrolaminar involvement of the optic nerve, as just mentioned. The resection margin is free of tumor cell, but the invasion of optic nerve goes beyond the lamina cribrosa. Most of these children are treated by chemotherapy in the world, although it is debated, and it is very strongly debated when there is only a massive choroidal invasion or an anterior chamber or segment involvement. Some people propose adjuvant chemotherapy, other people don't propose adjuvant chemotherapy. We'll discuss about that. When there is no optic nerve involvement and no choroidal involvement, everybody agrees that there should be no adjuvant treatment. And it is debated when there is only prelaminar optic nerve involvement and minimal choroidal involvement. In some centers, they give adjuvant chemotherapy. In some others, they don't. So this is very debated, and we have very weak conclusion. It's only based on mainly few prospective studies and mainly retrospective studies. It's very fragile criteria to decide. We have published, I think 4 years ago, a national prospective studies, like the one mentioned by the COG recently. So we included 123 patients with a median age at treatment of 23 months and a median follow-up of 71 months. More than half of these children could avoid chemotherapy after enucleation, 57%. 42% received 4 courses of chemotherapy, either for retrolaminar involvement and or massive choroidal involvement. And 1% only had, one child had high-risk features. So 57% did not receive chemotherapy, including minimal choroidal invasion or prelaminar optic nerve invasion. And we have 100% event-free survival, no extraocular relapse. So again, this is the classification, which is, of course, a nice way to progress and to talk together and compare studies and maybe to work together more efficiently. Obviously, we know that PT3A, massive choroidal invasion, PT3B, retrolaminar invasion, and PT3C and D with scleral invasion, there are discrepancies among centers, among countries, about the need for adjuvant chemotherapy. But as I mentioned initially, PT4, which means extraocular tumor, there is a consensus. All children should be treated not only with chemotherapy, but also with adjuvant radiation therapy. For the intermediate risk patients with PT3A and B especially, there is a philosophical debate, if I can say so. Should we choose to avoid adjuvant treatment and expose few children to extraocular relapse with a vital risk? If there is a CNS relapse, few patients or no patients will be cured. And if there is extra CNS relapse, metastatic relapse, of course, some patients may be cured, but not 100%. Or should we choose to propose adjuvant treatment, avoiding extraocular relapse, but exposing some children to overtreatment, because we know that some children with retrolaminar involvement even, or with massive choroidal involvement, may survive without adjuvant treatment. So it's a very complicated issue, and I think what we do is that we have a prospective study which proposes an adapted chemotherapy according to histopathological criteria, but I think we need to inform parents that these indications are debated, and although we are convinced, example for retrolaminar involvement, that we should treat by adjuvant chemotherapy, we have to mention that in some centers they don't. And also, we as also mentioned, we need to try to define new prognostic factors. For example, biological criteria in the tumor itself, in the tumor samples, or circulating biomarkers, whether in the blood or in the CSF. But all these biomarkers have to be validated on prospective studies. We cannot say any new marker that it is predictive because we don't know. So it has to be proven in prospective studies. We cannot use it. We cannot use them now. And when we feel that a bioprognostic marker might be important, we feel, but we don't know it. So we should not use it. We should demonstrate its prognostic value. So in our current national prospective study, we did decrease the treatment for massive choroidal involvement, the PT3A. We give only 2 courses of vincristine carboplatin with low cumulative doses. And in children with PT3B to D with retrolaminar or intrascleral involvement, we give 4 courses of chemotherapy, as we did in the previous study, with no extraocular relapse. These are the cumulative dose of drugs, etoposide, carboplatin, and cyclophosphamide. These are pretty low doses. There is never no risk, but the risk of renal or auditive toxicity of carboplatin, secondary malignancy to cyclophosphamide or etoposide, and hypofertility to cyclophosphamide, at these doses, these risks are very, very low. They are almost theoretical risk. So we did this philosophical choice, but we informed the parents that we don't take the risk of having an extraocular relapse. Maybe some children are overtreated, but we would like to avoid any extraocular relapse, and we don't observe in France any extraocular relapse for years now. And probably the most progress we could do is trying to work together in the world, and we are speaking about that. With the European group, the COG, and the Latin American group, we could do a very good prospective study, but we have to be very careful because the natural history of the disease is different when the diagnosis is made later. So, for instance, and we had this experience in Honduras, for instance, but in South and Central America, the natural history is still different from North America or Western Europe. So we have to take into account the variability. We may stratify by continent or by country, but we still need to work together because the events, as we call them, the extraocular relapse, are very, very rare. So if we want to be able to conclude on the need for adjuvant chemotherapy and the type of adjuvant chemotherapy, we need many patients with hopefully, very rare events. So we need to work globally rather than country by country or even continent by continent. And the high risk, the invasion, for instance, of the optic nerve margin, resection margin, the best would be to avoid that. And sometimes imaging may help. If you, as Dr. Gombos mentioned, if you see a large optic nerve involvement, I'm not talking about a small contrast enhancing lesion. No, I'm talking about an optic nerve mass. For that, we know if there is a primary enucleation, of course, the optic margin will be, the optic nerve margin will be positive, and here we have also extrascleral involvement. So for this, there is a need for neoadjuvant chemotherapy and also a double approach surgery using anterior and neurosurgical approach to be able to cure these children. We see very, very few of these children. We have seen 11 children in the last years among 936 retinoblastoma patients. It's a very rare circumstance in Western countries, but if we want to cure them, we should not enucleate them because we are sure to have very high histopathological risk factors. So in conclusion, we need an accurate staging before enucleation, and MRI is very important not to detect the histopathological risk factors, as mentioned by Dr. Gombos, but to detect extraocular disease in the orbit, either extrascleral or invasion of the optic nerve. We should be able then to avoid as-risk fixture. Resection margin often can be avoided. We don't observe that anymore. We have to have, obviously, a very accurate pathological exam. And I would like to conclude also about the secondary enucleation after failure of conservative treatment. It should not be performed too late, especially in unilateral retinoblastoma. No child should experience extraocular relapse after a conservative treatment attempt. This is a very important message in my view. I think we don't observe that, but I think we see patients from other countries with extraocular relapse after failure of conservative treatment. That should not happen. And I would like to make a strong advertisement for Retinostop Association with the parents present here. Maybe some of them you know there already. And with two important actions. One is Tino, and this big Tino has a removable eye. So it helps, of course, children, families, and brothers and sisters about explaining the surgery. And this book about my new eye is, in fact, I didn't find it on the internet this morning, I must say, but it's translated in English by one of the mother of Retinostop, who is born in United States. And it's very useful for children and families also. And you can find it on the retinostop.org. All right, I think this is the end, and I would like to thank all the retinoblastoma team in Curie, and I am happy to answer any questions with my colleagues.
Thank you. The next presenter is Dr. Morali Chintagumpala.
Thank you, Patty. Thank you for the kind invitation. Thanks to the organizers. It's always a tricky proposition to be the last speaker before lunch. You could be trampled. So I think a lot has been covered by the previous speakers. What I'm going to do now is to give you an idea about the Children's Oncology Group experience with the prospective trial that we conducted that Patty just mentioned a few moments ago. As you all know, retinoblastoma is highly curable in developed countries. More than 90% of the children survive this disease. Enucleation, as was mentioned this morning, is one of the definitive treatments for patients with advanced unilateral disease, and it's widely accepted, although there are new treatments now to preserve the globe. However, after enucleation, 5 to 10% develop metastases, and these generally have a poor outcome, poorer than those who do not have metastatic disease who get enucleated and do well. Histopathologic features can predict metastases. Everybody agrees about that, except that nobody knows what those histopathologic features. They do know them, but they don't agree consistently. There's no consensus. So there have been a number of publications in late 80s and early 90s, as you can see. Most of these are retrospective studies with no clear guidelines as to what the histopathologic factors are, no clear measurements, no clear definitions, just a vague reference as to massive, focal, so on and so forth. Choroidal invasion of retinoblastoma, especially when associated with any degree of optic nerve invasion, Carol Shields had published that, and that's where we get this combination of prelaminar, laminar with any focal choroid invasion would constitute a high-risk feature. Optic nerve invasion beyond the lamina is associated with metastatic risk, and this has been written by many committees, and everybody agrees that this is a definite risk. Mortality rate of patients with grades 1, 2, 3, and 4 optic nerve involvement, as Patty had shown in her figure, which I will also show later on, has an increasing risk of metastases the farther you go from the prelaminar to the optic nerve cut end. 5-year metastatic risks were associated with optic nerve invasion, choroid involvement, and delay of greater than 120 days from initial diagnosis. Invasion of ocular coats and optic nerve risk factors for mortality was established by Koppelman et al. Chantada from Argentina had published 3 articles about high-risk features in 2003, 2004, 2007. These are overlapping populations. These are retrospective studies. The conclusions were that choroid invasion, massive choroid invasion, is probably not a risk factor. Again, post-laminar optic nerve involvement by its own may not be a risk factor, but when you combine the both, post-laminar optic nerve invasion and massive choroidal invasion, then that would constitute a true high-risk feature. But he goes on to say, adjuvant chemotherapy without these associated risk factors is more controversial because some chemotherapy-naive relapsing patients may be rescued with current high-dose therapy. You know, you have to weigh that against treating upfront a certain number of children who may not require chemotherapy. But on the other hand, if some of them do recur, the amount of chemotherapy and radiation therapy that you give them does put them at considerable risk, and then there's this risk of second malignancy later on in life. So you have to weigh it against that. It's better to treat them upfront with clearly defined factors than trying to salvage them later on. At least that's my opinion. So this is a slide that I borrowed from Patty. This is a lesson for me. Never include pathology slides when you have a world-renowned pathologist already in the session, okay? So note to myself. So again, the risk factor, this is the retinal layer. Choroid, it's important because all the vascular spaces are in the choroid. So you can easily imagine if the choroid is involved, through these microvessels, the tumor cells can spread elsewhere to the lymph nodes, to the bone, to the liver, bone marrow, so on and so forth. That's the critical thing about the choroid, why choroid involvement is so important. How to prevent Mets following enucleation? First of all, you have to understand the risk factors predictive of metastases, and then you have to take action, adjuvant chemotherapy, because retinoblastoma, as you all know, is very responsive to chemotherapy, very responsive to radiation therapy. Obviously, we won't use radiation therapy if we can get away with it in the younger patients. But there are challenges in identifying risk factors. As Patty pointed out, it's critical how you process the eye, how you open the globe, how you assess the pathologic features, very critical. And it's not uniform. Most of the institution pathologists see 2 or 3 retinoblastoma cases a year, if at all, unless you get to the large centers. Everybody sends their specimens to Patty. She sees hundreds of them, obviously, so Clearly, we have that expertise in Houston. So variations in processing of pathology specimen interpretation of pathology would be, when you look at studies, it's very difficult to arrive at a conclusion because there's so much variation. Lack of universally accepted uniform criteria to define risk factors. So what is choroid invasion? If you say focal and massive and I say less than 3 millimeters and greater than 3 millimeters, which is more precise? Clearly the latter. The number of patients developing metastatic disease after enucleation is small, so the randomized trials are not really feasible. That's another problem. You have these breast cancer, prostate cancer studies, you have 30,000, 40,000 patients, you can randomize, do all sorts of studies. In North America, you have 300, at least in the United States, you have 300 patients a year newly diagnosed. How do you randomize them and how do you assess the efficacy of adjuvant therapy and assess the risk factors? Tough. And I agree with François. In fact, we've been talking since, I think, SIOP last year to form this international collaboration. Previous publications on this topic are from single institutions, most often, retrospective, with no detailed discussion, which I've mentioned. This is important. Central review by a panel of experienced ophthalmic pathologists, or at least by a single experienced ophthalmic pathologist, so there is some uniformity. What several institutions may call as high-risk feature may not be a high-risk feature, as I'll show you in the next few slides. So again, these are slides that Patty had given me. And so our definition of focal and massive, it's important. So this is nobody can make a mistake on this. When you say 3 millimeter, you got it, right? So it's not vague like massive and focal. Optic nerve invasion. This is the only study that showed increasing risk of metastases from 10% to close to 80% as you progress from prelaminar to cut end. But I think we all agree now the prelaminar and laminar involvement are not that much of an issue. And again, these are examples of prelaminar, laminar, post-laminar, and this is cut end of optic nerve. Clearly, this is important. So we did a prospective study because there's never been a prospective study looking at pathologic features with a central review. To prospectively determine, to carefully log in all the high-risk pathologic features that we want to study, and to demonstrate that patients without certain high-risk features can be successfully treated with enucleation and observation. Whereas on the high-risk features that we agreed upon that require treatment, we can treat them with 6 cycles of chemotherapy and again have a very good outcome. So that was the purpose of this study. These are the high-risk features we wanted to look at. Posterior uveal invasion includes choroidal invasion, any degree of concomitant choroid and optic nerve involvement, tumor involving the optic nerve posterior to the lamina is an independent finding, and the rest of them, scleral invasion, anterior chamber, again, all these have been described as high-risk features in the past. Only a subset of the above features are indications for chemotherapy. We didn't want to treat all of them. The ones that we picked were massive choroid replacement, grades 2C and 2D, that is greater than 3 millimeters. Any posterior uveal involvement with any optic nerve involvement. This was based on Carol Shields' article in the past. And then the last one was optic nerve involvement posterior to the lamina as an independent finding. So again, we established a central review, uniformly define and identify histopathologic features, just as I showed you. This will minimize diagnostic error, and patients receive appropriate therapy. And patients who do not require chemotherapy will not be exposed to it based on central review, which is important. We had strict criteria. Pathology slides had to be submitted within 21 days of surgery, central review to be performed within 7 days, which worked very well. Chemotherapy, if indicated, to be started no later than 35 days from surgery. So this is the schema. Obviously, no high-risk features we observed. High-risk features, adjuvant therapy, 6 cycles of chemotherapy, no metastases, we followed. Any of these 2 arms, if they had metastatic disease, they went on to other protocols. Pretty simple. We accrued 331 patients. accrual went very well, especially when we included 2 institutions in India too. It really took off. This is the largest prospective study looking at high-risk features in unilateral retinoblastoma, newly diagnosed. This is an important slide. This is what makes the central review so important. If you look at the institutional risk classification, they said 235 patients did not have high-risk features, whereas upon central review, 13% of them were considered high risk and required therapy. Again, when you look at the institutional risk classification, they classified 89 as high risk. Central review said 24% of these patients actually did not require chemotherapy. These are large numbers by any account. So this again brings up the issue of central review. If we are ever to do an international study, central review would be important. Preliminary results suggest that careful assessment of histopathology with strict criteria for intervention and adjuvant therapy may further improve the outcome of children who undergo enucleation at diagnosis. We can reliably avoid chemotherapy in approximately 70% of these children. In fact, it's a little bit more. If you actually eliminate the second criteria, that any degree of concomitant optic nerve and any degree of choroid involvement, meaning if you have prelaminar, laminar optic involvement with focal choroidal involvement, I don't think those patients require therapy. At least that's our feeling now. There were only 15 such patients in the study. Still, so that'll raise it to a little bit above 70%. Isolated anterior chamber scleral invasion, iris, and ciliary may not require adjuvant therapy. Actually, we found none of these were isolated findings in our study. I mean, if you look at 331 patients, Patty, I think you agree with me, they were always associated with either massive choroidal invasion or post-laminar, one of the really high-risk features which required chemotherapy anyway. So we never found isolated findings, okay, related to this. More intensive therapy is needed for selected patients with certain, the ones that Patty showed, which had concomitant, massive, post-laminar optic nerve involvement and massive choroid involvement. I think those pose a special risk, and we need to address that issue. Whether we need to treat them as aggressively as orbital disease, that is something we need to think about. The truly high-risk features, this is a study that we also did through COG. Ira Dunkel is the study chair for this. Patty and I did the previous one with a bunch of study committee people. These are truly high-risk features. These are obvious, right? These are extraocular disease. Stages 2 and 3, orbital disease, regional nodes, optic nerve margin. 4A is distant mets, not CNS, but distant mets. 4B is CNS disease. So we wanted to study them, event-free survival in 3 groups of patients to estimate the response rate to induction to evaluate the toxicities of the regimen. This is a pretty intensive regimen, obviously, as you can imagine, because this is metastatic disease. So we did several cycles of chemotherapy up front according to a brain tumor protocol, then did stem cell harvest, and then did 1 transplant, high-dose chemotherapy, stem cell rescue, radiation therapy for all stages if there's a less than CR. We actually accrued quite a few patients on this study. We targeted 20 patients for each of these, and we're pretty close to it. The results of this study will be presented at SIOP by Ira Dunkel. Pretty exciting, actually. The only thing I can tell you is non-CNS disease is highly curable with this treatment, but if a CNS is involved, the prognosis is still dismal in spite of all this intensive therapy. So that's something we need to look into. As Patty pointed out, maybe the CSF analysis earlier on can make us detect these patients very early and treat them aggressively, but that's something we need to talk about. Conclusions. Cooperative group studies shed significant light on long-standing issues in retinoblastoma. We strongly believe this, and I think there should be strong movement to enroll patients on cooperative group study. Isolated institutional studies, small studies done well would provide the proof of principle, but to be proven, it has to be brought to a larger setting with a larger number of patients so that we can once and for all declare that something works or something doesn't work. Large prospective studies are necessary in addressing important issues. Again, we should look at international cooperation. There you go. That's the last one. Attempt should be made to perform international studies. I'll stop here.
Well, in interest of time, I think we can have the 5 minutes more? Okay. Any questions? Yes.
Hi, I'm Bhavna Chawla. I come from India. And at our center, we have about 40% of enucleated eyes with high-risk histopathology. My question is for those patients who have been first treated conservatively and then they undergo an enucleation. Many of these enucleated eyes exhibit high-risk features. So in those cases, what would be your protocol for adjuvant therapy in the form of chemotherapy? Those who have already received, say, 2, 4, or 6 cycles of systemic chemotherapy and still exhibiting high-risk features in the enucleated eye.
François.
It's of course a difficult question. Obviously, we would indicate adjuvant chemotherapy after secondary enucleation if there is histopathological risk factors, and then think about what is the reason of failure of previous conservative treatments. Because often, I don't know if you will confirm, but in our experience, even conservative treatments, including systemic chemotherapy, the failure is more on the vitreous and maybe sometimes in the subretinal fluid than on the retinal tumors themselves. So probably intrinsically, the tumor cells are not resistant. The problem is the access of the tumor cells which are in the vitreous body or in the subretinal space, which is less good. So we dare to use adjuvant chemotherapy, even using the same drugs than the conservative attempt, because it's more, it's not intrinsic resistance of tumor cells, rather difficulty to preserve the eye with vitreous involvement. So we use exactly the same drugs that we do use for our first-line enucleation protocol, which is VP16 carboplatin vincristine cyclo.
Morali, can you?
Yeah. This is an even more controversial issue. It's very hard to assess the risk factor here, especially if the choroid alone is involved after all the therapy and you nucleate. We have often not treated those children with subsequent chemotherapy. If there's post-laminar optic nerve, that would make a strong case. Then the question is, you're left with only so many chemotherapy regimens. And the question is whether to use doxorubicin-based therapy or topotecan-based therapy. You could use any of those. But generally speaking, it's not clear, for example, if the choroid is involved post-treatment, if that's a risk factor. We feel it probably isn't, and there are not that many cases that we come across anyway to begin with in the developed countries, so that's even more controversial.
I have a question for the panel regarding isolated massive choroidal invasion. I think we're getting more comfortable in not treating isolated anterior segment and then those patients with prelaminar combined with focal choroidal invasion. But isolated massive choroidal invasion remains really very controversial. It seems like in your prospective study, you went ahead and treated all those patients. You considered it a high-risk feature. In the retrospective review that I did with Arun Singh, the risks seem to be about 5 to 6%. So maybe you could talk about the rationale for treating massive choroidal invasion when it's isolated.
We have
let me just answer. In the table I presented, I didn't go in much detail, but one of the cases that recur with systemic metastasis in bone marrow was a choroidal massive choroidal invasion in the group that was not treated. So that patient never got treated because this was an initial case that only the pathologists were only sending the PO section, the central section of the eye, and they did not send the calots. So when this patient presented, we saw the slide and it didn't have any high-risk feature. Then the patient presented with metastasis. We asked for the calots, they had saved it in formalin, so we processed it and it had massive choroidal invasion. So the only risk factor in that patient was massive choroidal invasion and it recurred as a metastasis. Now, it was saved with the new therapy for metastatic disease, but it happens.
I think so. It should be treated.
what we do is, as I shown in our current protocol, because we have shown in our retrospective studies that it was a risk factor more than 20 years ago, so we never dare not to use chemotherapy, but now we use only 2 courses of vincristine carboplatin, which is a very low dose of chemotherapy. So it's very short and very low cumulative dose, and the risk of chemotherapy is very, very, very low. And the thing is back to the philosophical question. Should we treat all children with choroidal invasion and have no extraocular relapse? Or should we not treat any of them as a principle, but then be ready to treat extraocular relapse, which again, even when it is not within the CNS, this is very hard treatment, very high cumulative doses, very dangerous treatments, and when it is not 100% survival, even when it is not in the CNS. So it's really, I would be interested to have the opinion of parents around here. We constructed our protocol with parents in France with Retinoblastoma Association, and the people who are in this association, it's a bias of parents' recruitment, but they were all in favor of treatment to avoid the risk of extraocular relapse. I think it would be an interesting debate with parents.
So I think just an informal poll, if your child had a 5% risk of metastatic disease with massive choroidal, and we could reduce that significantly with active chemotherapy, there's a 95% chance that they did need treatment. How many parents would elect to treat in that situation? Sure. If your child had a 5% risk of having metastatic disease, and we could reduce that significantly by giving adjuvant chemotherapy, let's say 6 courses, but there's a 95% chance that they didn't need the chemotherapy, how many parents would elect to treat in that situation?
But Jonathan, how did you get that 5% thing? You know, I think nobody has carefully looked at the definition and then looked at the choroid involvement. And if you just took all the patients who had greater than 3 millimeter choroid involvement and then decide that 95% of them who did not require treatment did well, then yes, we would say, okay, there's a 5% risk. If that's the way you did it, if there's a retrospective study, that would be an issue.
I did an analysis for Arun's journal article, looking at all the retrospective studies on isolated massive choroidal invasion untreated, and I got a 6% risk.
I understand, but the problem with all those studies is there's no clear definition. None of the pathology, there was no central review. You look at the difficulty in assessing the risk factor based on what Patty just showed you, looking at the specimens and how it's processed. In fact, we haven't gone through the details of the pathologic inconsistencies of the specimens that were submitted. That's going to come out in the manuscript. But it's not easy to process and interpret these findings. So when they say massive, isolated, we don't know what exactly that means in retrospective studies. This was years ago.
So you're saying that perhaps some of those cases were focal, maybe the actual risk is a little bit higher. But,
absolutely.
But we need to give parents some sort of number, don't we? Or we need to have some sort of number to discuss among ourselves.
If we have it, we need to give. We don't have it.
So in your slide, Patty, you showed 2 out of 42 patients with massive choroidal developing relapse in one of your slides.
Yes. So the slide that I show, all of the patients that we diagnosed as massive choroidal invasion they were treated with adjuvant chemotherapy. Only one case was not diagnosed because I said we didn't have the tissue, and that is the only case that recur. From the others, the only ones that recur are the ones with concomitant optic nerve invasion, massive. So none of the single choroidal invasion massive that we treated recur.
Okay, I just wanted to make the final point that we don't really have any control studies to prove that adjuvant therapy is effective, correct? We have lots of studies saying there's low rates after treatment, but no one's really ever proven that adjuvant therapy is effective.
One other point that I think we really need to emphasize here, and this is, we see this increasingly, someone is told that they have high-risk histopathology, and then those slides come to a specialist and we learn that they don't. We've seen patients who've gotten systemic chemotherapy who didn't need it. We really, if there's one take-home point that I would say to a parent, is make sure to review who's looking at the pathology. We're surrounded here by specialist centers with experts, but how many children's pathology never gets reviewed by that level of expertise? We shouldn't underestimate that. And this is an extraordinary area where the parent may not even be involved. Their interaction is with the clinician, it's with the pediatric oncologist, but who's reviewed the pathology? And that, I think, is the weak link in a lot of these questions. We don't know. So much of this historically did not have strict definition. This definition of 3 millimeters is fairly new historically. All the previous papers used these various definitions. At least we now have a definition. But I would even argue that in many prior papers we have to question who's looked at the pathology and how was it reviewed and who's reviewed it. And a key step going forward is making sure that we're all looking at the same definition, patient population, and review things, prospectively, because there's a question mark there. There's a gray zone in all these retrospective reviews that I think Morali has pointed out, and even the COG trial has demonstrated that without central review, we can be wrong in that definition, and we're basing everything on that. Brenda, you have your hand up.
Just what you just said, the error that the local pathologists made. It's important in that study that the error, not just the error is over-diagnosing the risk, not under-diagnosing it. So that leading to children being treated who did not need the treatment. So that to me is a really powerful thing for the parents to know that why it's so important that the pathology be expert.
Yeah, and we also have the underdiagnosis because of not processing properly the eye.
Can I just ask one other question? Okay. Of all the patients that receive adjuvant treatment, what portion of those go on to need further treatment or fail that? So we have a subset of people that get prophylactic chemotherapy that are at high risk, but of those high risks, some of them, even after treatment, go on to have disease. What percentage that? Is that?
In the table we presented, there were 5 patients of 313. But only two, the ones that we had treated only, there were 3.
None. No patient had extraocular relapse after this prospective study on 120 patients. None.
And the patients who were observed in the same study, 2 of them failed. One because there was a puncture of the globe, which they didn't mention, and they just enrolled the patient on study and later recurred. And one was the case of the choroid involvement, which wasn't detected at the time of entry into the study. Those were the only 2 who failed in the observation arm, meaning out of 330 patients, 93 received adjuvant therapy. The rest did not. Significant majority of them, more than 70%, did not. And of those, only 2 failed because of obvious reasons. And they survived with subsequent therapy. 100% survival on the observation arm. The ones that failed really had bad disease. I mean, those are ones that we need to figure out how best to treat them prospectively.
Of 93, 3.
So 3 out of 9.
Before the microphone change the hand, I would like to still raise the question to parents here. Who would be in favor of treating with histopathological risk factor
Confirm.
at intermediate histopathological risk factor, even if the risk of extraocular relapse is low, or who would rather not treat and be ready to expect extraocular relapse and then treat for these very high-risk patients? I think it's a very interesting debate and philosophically important.
But to have that debate, you have to really explain to the parents what that chemotherapy entails, because not all chemotherapy is the same, not all radiation is the same. You know, it's not the same treatment, so that has to be part of the discussion.
She has a question. Can you give her a question to, the microphone? I'm so sorry, but that This is the last question we have to, her. She's a,
In all of this, I think we also have to keep in mind numbers needed to treat. So you're going to treat 93 cases or 100 cases to stop metastasis in 2. So numbers are good, survivals are good, all those are good, but number needed to treat quantifies the benefit.
I just very quickly wanted to give a parent's perspective on that debate because we very much faced that debate, and we decided not to treat. I think most of you would agree that that was the correct way about it for specific reasons to our case. But actually, it was a very difficult decision to make because of the lack of data. And I don't think I'm overstating things when I say that probably for me, the most frustrating and difficult part of this whole journey has been the frustration at there's no data to, or at least I don't have access to good enough data to answer my questions. So, and I actually was very fortunate. I have a wonderful local hospital in Barcelona. We actually got a second with the Institut Curie of the pathology of my daughter. We were in contact with the St. Jude, so I believe I was, very, very fortunate to be in touch with the best professionals out there. Yet, I wasn't able to get, answers to the question, but what are the real risks? And I believe it's just because, the medical community hasn't put together that data. I understand it's difficult, but from a parent's perspective, it was just a terrible decision to be made because we felt we were making it a little bit in the dark.
but your daughter didn't have any high-risk histopathology.
She
No.
don't have high risk, but we still got the advice from some doctors to give her adjuvant.
Yeah, I remember.
Because it was a very large tumor with a glaucoma. And it was a very difficult presentation. I understand that made a lot of doctors pause a little bit, even though there weren't technically any high-risk factors.
The only way this will get solved is to do the international study, a randomized study, because I think people in South America, too bad Guillermo is not here, but they don't think, as some of us here, that choroid involvement is a risk factor. Well, they think massive choroid, whatever that means. So they don't treat that. So if we do the international study, there might be an option where the South American institutions may not treat choroid invasion. François' group may do 2 cycles, and we may do 6 cycles, and we can figure out the events, and maybe that might be a better, given the fact that the biology again might be different in the 3 continents. That's a different issue. 2 continents, 3. So we have to think about that. Maybe that's the only way to figure out, because you can say, well, we treated, we got good results. Somebody may say we didn't treat, we got good results. So what does this actually mean? If you have uniform criteria, central review, and some institutions prefer not to treat, then we should take that. And if the families there and the physicians there are comfortable with it, that could be one arm of the study. And I think that's the only way it's going to be done. François?
Yes, but it is everything but randomization. It's
not randomization, yeah.
Okay, well, we have to finish because we really are over the time. Thank you very much for your attention. And do you want to say something?
Thank you, everyone. We have lunch next door, and we are going to start on time at 1:45. So if you guys can all make sure that you're back in time for that. Thank you.